Hi, in this unit we're going to talk about those additives we might put together with either off-the-shelf replacement or maintenance solution, and we will be talking about them one at a time. Each of these special components has special considerations that are very important for you to recognize when you're adding them to supplement these other solutions. One of the more common electrolytes that we will replace in an animal is potassium, and this is obviously the indication for this is when they have hypokalemia. When they have hyperkalemia, we obviously want to avoid potassium, and we may want to use a more sodium dominating. Most of these solutions we've talked about are sodium dominant solution in large quantities even. And the main reason we're concerned about either hypo or hyperkalemia has to do with the as you'll learn in your cardiovascular units, and electrically excitable membranes are impacted by the sodium and potassium ratio between the extracellular fluid and the intracellular fluid. So we want to impact that, and we know when we have high amounts of potassium, for example, we can lead to cardiac arrhythmias. When we have low potassium, we can have cardiac arrhythmias. So just like with the fluid requirements, we have maintenance needs for potassium. And what are these? Generally, a rule of thumb is to think that an animal would normally take into via its diet 2 milliequivalents per kilogram per day. And so you'll see when we consider an animal that is not eating, we would want to make sure in calculating a maintenance fluid administration for potassium that we would consider this total requirement per day. So at a maintenance fluid rate, which we said in a dog is say 60 milliliters per kilogram, what would be the potassium concentration we'd have to put in that solution in order to maintain potassium and provide the 2 milliequivalents per kilogram per day? Well, it would be 30 to 35 milliequivalents per liter. And so if you go back and look at the solution concentrations of most of the fluids, or even those considered to be maintenance, we are well below that with potassium. So that generally has to be added. And one thing to note about potassium in considering hypokalemia, we want to avoid it. We want to avoid developing hypokalemia, and that's because most of the potassium, you might recall, is inside the cell. And so when we see it being low outside the cell, we will already have 20% whole body depletion. And that's something to consider. So once you have real hypokalemia, it's generally pretty severe. And also to remember, and we'll show you an example of this, that potassium can shift from outside the cell to inside the cell, to outside the cell when we have metabolic acidosis. And I'll show you the mechanism for that. In this slide, I'd like to show you a table you can find in a lot of critical care textbooks, but it helps you think about potassium and the limitations we have for it. First of all, notice on the left-hand column the potassium concentrations that you might have. So over on this side, if you have mildly depressed potassium to severely depressed potassium, the amount of potassium that could be administered into the final concentration solution would be in the second column. And yet, we have a maximum at which we can give this potassium per hour. And this is a figure to keep in the back of your mind, even if you go back and look it up before calculating adding potassium. I've given you some examples to show that as you add more and more potassium, it really slow down the amount of fluids you could give per hour to that animal. Most of the time we don't get near this, these risky rates, but you need to keep it in mind. It's always a good exercise to calculate the amount of potassium that you're giving per hour, just to see how close you are to that. In case the animal, its catheter kinks and then unkinks, or anything like that that would lead to massive amounts being given. And remember, we're trying to avoid stoppage of the heart. So this gets to the toxicities we see of potassium salts. The major one intravenously is cardiac toxicity, and that's generally, as I said, you don't want to exceed 0.5 milliequivalent per kilogram per hour. How do you monitor? Well, you can monitor for ECG changes, and what you look for, particularly when you're giving aggressive parenteral potassium therapy, would be spiked or inverted T waves, prolonged PR interval, or actual atrial standstill, which is a precursor to stoppage of the heart. Essentially, you're stopping the normal electrical rhythm being driven from the atria. And this is something you could also see in a severely hyperkalemic animal that might have, say, Addison's disease, where mineralocorticoids are deficient. Potassium, if given subcutaneously, either on purpose or by mistake, will be irritative. So you definitely don't want to give high amounts of potassium in that way. And when you have potassium administration going on, because the kidneys are really important buffer, if you will, it's an organ that you'll learn about, handles a lot of potassium and can adjust for your potential overdose. If the kidney function is marginal, you definitely want, you probably don't want to push the potassium. So and you also want to check the renal function, usually by measuring creatinine or BUN, before the administration. So what are potassium supplements? Well, we have oral supplements that can be given quite safely. Elixir, potassium gluconate, called K-on or slow K or micro K. And then you have parenteral, and that's usually potassium chloride or potassium phosphate. And the main thing to keep in mind is the amount of potassium milliequivalents that you're administering. It will vary depending on what the anion is. So the indications, as I said, will be obviously low potassium is one clear indication. Some ECG changes, generalized weakness, and any history of, say, a lot of vomiting or diarrhea that could lead to the animal, or just fasting that could lead the animal to lose potassium because it's not taking it in orally. Now I'd like to describe how the influence of pH in the bloodstream will alter potassium concentrations. And basically, what we're looking at here, we're going to start right here on the left, looking at the potassium and hydrogen ions in the extracellular and intracellular fluid compartments. And so the scenario we want to look at first is one that's called alkalosis. And alkalosis is obviously a reduction of hydrogen ions. And that's what's reflected on the left. And so when that happens, what happens if we go to the middle compartment here, just to the next stage, there is the hydrogen to potassium exchanger that basically will take hydrogen from inside the cell and drive it through this exchanger, driving potassium into the cell. And that will lead to, obviously, ameliorate some of the, it will push the potassium, the hydrogen ions up in the extracellular fluid, but it will push the potassium down further. So what do we end up with? We end up with alkalosis ending up being more mild, but with a more severe hypokalemia. So we end up with hypokalemia with alkalosis. So, what about the opposite situation? The opposite situation is acidosis. So, a metabolic acidosis. And obviously that's when hydrogen ions are elevated. And so what's happening here, it's the same exchanger, hydrogen and potassium ions on the cell membranes. But in this case, hydrogen ions are going to be going down their gradient with this exchanger, taking the potassium that's inside the cell in high quantities and pushing it out. And so what happens is, with acidosis, we get a hyperkalemia. So another common additive you might make to a solution for fluid replacement would be glucose, dextrose. And the obvious indication for this would be hypoglycemia. You might want to use dextrose in order to cause a diuresis. You might use a very high concentration of dextrose, even as much as 30%, to cause osmotic diuresis. That means it draws fluid into the extracellular fluid and then pushes that through the kidneys, and so it causes what we call an osmotic diuresis. You can add glucose as part of the caloric needs and when you are treating a diabetic ketoacidosis, because it's hard to give insulin without driving the glucose down too low. You definitely can use it separate from a diabetic situation in an animal that has hyperkalemia. And this is due to the fact that insulin stimulates sodium potassium ATPase that will actually help correct hyperkalemia. So anything that increases insulin, either insulin itself or glucose administered in high quantities stimulating insulin, will lead to this stimulation of sodium potassium ATPase. Now, when you give insulin, it's a good idea not to just give insulin, because you're going to drive the glucose down in a normal glycemic animal. So you definitely want to put insulin with glucose, but you could also just give glucose and see if the insulin is stimulated endogenously. So some of the pharmaceutical considerations for 5% dextrose, D5W, you may know from the ER shows, is that it provides free water. However, by itself, it's acidic, 4.2. It should not be used as caloric maintenance. It's very difficult to give enough dextrose to maintain an animal. So that's why we don't see dextrose being given in addition to other concerns about catheter maintenance and things like that. They're very good. Obviously, glucose is a very good bacterial medium. If we need more calories, we generally use other means of giving those calories to an animal, such as putting in an intragastric or esophageal gastric tube. And remember that glucose will stimulate insulin, therefore it will increase potassium uptake in the cells, so we have to keep in mind that we can use that to our advantage if potassium is elevated, but if we use high amounts of dextrose, may also cause some hypokalemia if we're not adequately replacing potassium. So the adverse effects for glucose can be infection and phlebitis, that is inflammation of the vein, if given in too high a concentration or given sub-Q. And an overdose can lead to osmotic loss of water, causing an increase in aldosterone and then further sodium loss. Now, like I said before, we can use dextrose in high quantity as an osmotic diuretic, but there will be what we're talking about are the adjustments that the kidney and the adrenal glands make to lead to aldosterone and then sodium loss as well. So it won't be just water, it'll be sodium going along with it into the urine. Another additive you might see used is sodium bicarbonate, and indications are obviously the condition called metabolic acidosis. And you'll learn more in medicine, but I thought it's worthwhile mentioning briefly that you can have a metabolic acidosis in which the anion gap is normal. The anion gap is represented by this equation right here, where you're basically taking the two major cations, sodium and potassium, and subtracting the two major anions. And this can occur with a kidney disease like what's called renal tubular acidosis. You can have a high anion gap, and this can be due to either a hypoxic situation where a lot of lactic acid is being developed, and so that anion that's being developed that you don't measure in that formula is lactic acid. And then you can have one situation where the animal has got a normal PO2, and this is with, I already mentioned, renal failure which is a failure of secretion of the acid ions, diabetic ketoacidosis, where you have ketone bodies, or possibly anaphrase toxicosis, where the anions are oxalic acid and lactic acid. And any situation where you have an acidosis, the best thing to do is to try to reverse the primary cause, because there are significant risks to, particularly to too rapidly normalizing the pH through the use of bicarbonate, and we'll talk about those coming up. So the adverse effects would be, and I've given you a formula here that you can refer to later for correcting an acidosis. As you notice, you don't correct the entire cellular volume, water volume of the animal. You do about half of it. So you do it slowly, because you want to avoid rapid administration to allow all of those compartments, the plasma volume and the interstitial volume and the intracellular volume, to equilibrate. In large animals, for milder conditions, we can give bicarbonate orally. Now, talking mostly about IV administration, the adverse effects are high amounts of sodium, because it's sodium bicarbonate, increased extracellular hyperosmolality results, a possible low potassium because of that sodium, and a high calcium. Now, why is that? Well, that relates to what we talked about with regards to, and we'll talk about in the calcium unit, with regards to the pH increasing will lead to binding of calcium to serum albumin, because hydrogen and hydrogen and calcium compete for albumin. We can have what's called a paradoxical CSF acidosis. That is the more rapid driving of the pH inside the cerebral spinal fluid, increase in CO2. CO2 then says to the respiratory center in the medulla, oh, I'm going to stop the breathing, because, and this can lead to death. So what we call paradoxical CSF acidosis is due to that extra CO2 in the CSF, and that can lead to death and stoppage of breathing. We can also have intracranial hemorrhage and coma, and decreased blood oxygen availability with bicarb, increased morbidity and mortality, primarily due to that CSF acidosis. Now, calcium salts can be given, and this, obviously, the indication for this would be severe hypocalcemia. Best examples being what's called milk fever that occurs around and shortly after parturition in cattle, in dairy cattle, and in primary, which means PTH deficiency, or surgical hypoparathyroidism, which we can see, for instance, when we thyroidectomize a cat and we've damaged or removed the parathyroid glands. We may need to give calcium. Before you administer calcium, make sure the kidneys are functioning, and I've given you the dose. You can look that up in any formulary as well. The dangers you have of giving calcium too rapidly have to do with the calcium phosphate balance. And remember that there's a solubility product, so if calcium concentration times phosphate exceeds a certain amount, then you can get the precipitation, you get basically precipitates in the soft tissues. And we'll talk about that more in the calcium units. But the dangers become, particularly for the kidney, deposition of calcium can be almost irreversible process leading to renal failure. Soft tissue mineralization, deposition in fat is not so big a deal. Cardiac arrhythmias can be a problem, so you have to monitor ECGs when you give calcium. Oral calcium supplementation is relatively safe. And you have calcium carbonate, citrate, and gluconate. The main side effect that you'll see here might be constipation, if the calcium is given in excess. What about phosphate? Now, phosphate, or potassium, usually given as a solution of potassium phosphate, is indicated when phosphate becomes usually less than 1 to 1.5 milligrams per deciliter, because of the tendency for an hemolytic process occurring with red blood cells. You often will replace, you'll see potassium and phosphate falling with potassium falling, sometimes with magnesium as well. So the two conditions we see the need to sometimes replace potassium are in hemolytic anemias and where we're getting massive amounts of phosphate from intracellular red blood cells being lost into the blood and then put into the urine, and we need to replace that. Or diabetic ketoacidosis, which in this case helps us to address the phosphate loss as well as the potassium loss. Now, magnesium is that other divalent cation, and you'll see magnesium supplementation. The most dramatic one will be in the Downer cow, where you have an animal that's not capable of generating muscular contraction because of hypocalcemia and usually associated with hypomagnesemia, and they'll need the calcium and magnesium in order to stand up. We also, as I mentioned, will see the magnesium deficiency in dogs and cats with diabetic ketoacidosis if it's severe. We have products that can be given orally. Epsom salts is a good example, or for parenteral use, magnesium phosphate, and I'm giving you some doses here that you could also look up. So magnesium is not given all that commonly, except in these special circumstances. So in summary about the fluid additives, potassium is the most commonly supplemented electrolyte. Altered pH can impact plasma potassium through that hydrogen-potassium exchange in the cell membrane. Dextrose cannot be given safely IV at a rate necessary or adequate to maintain caloric needs. So if we have the need to keep the animal essentially with enough calories, we usually have to use other means, nutritional means, to provide those calories. Acidosis is treated with sodium bicarbonate, but we ought to try to treat the primary causes of acidosis first. For example, if it's diabetic ketoacidosis, give the insulin, try to reverse the acidosis first in a more by replacing the substance, the insulin, that's the primary deficiency, and then be more cautious with your sodium bicarbonate administration, both in terms of the rate at which you give it, but also whether you give it at all, because of this CSF acidosis that can lead to respiratory stoppage and death. Calcium salts are being used to treat milk fever and primary hypoparathyroidism, whether it be iatrogenic or caused by surgery or by an idiopathic form, hypoparathyroidism. Potassium, phosphate, and magnesium depletion can often occur together.